Good evening. Okay, folks, before we actually start the program, a little bit of housekeeping. Um, I'm Dave Sargent, a member of the Miracle Living Committee. And let's see, very important item first. If you got cell phone with you, please silence it. Thank you very much. In case you aren't aware of it, the restrooms are right across the hall, dead easy to find. The process that we're using, which if you are new, I want everybody to listen if you happen to be new. Process is that after I introduce our moderator this evening, um, moderator will kick the lectures off and the lecturers will do their thing. And then there's a break and Miracle Living Committee members will come around with pieces of paper to collect your questions for the panel. And we don't allow questions yelled up from the audience because they don't make it clearly onto the audio system, which connects with the people that are also watching on Zoom. So we want to make sure everybody hears the questions. Otherwise, the answers don't often make a whole lot of sense. Okay. For your interest, the next lecture is on the subject of stroke, what you really need to know, on May 20th. And that one will also be here in this room. Hopefully, it'll be the last one before the Hoffman Conference Center is refurbished and we go back across the street over there. Okay, enough housekeeping. It's now my pleasure to introduce our moderator, Dr. Lana Shi. And Dr. Shi is a board-certified family medicine physician who completed her medical degree at the University of California, Davis, after earning her undergrad degree in biology with honors from UCLA. She pursued her residency training in family medicine at Harbor UCLA Medical Center, where she further advanced her expertise through a faculty development fellowship with a focus on women's health. Dr. Shi is passionate about caring for diverse patient populations, including reproductive health, weight management, and chronic disease management. She believes deeply in working together with her patients to meet their unique health goals at every stage of life. Please help me welcome Dr. Shi.
Hello, good evening. Thank you everyone for making it out today. I actually quite like the new location. It's very cozy. I think this is a really great opportunity for us to kind of, have some conversation with the community. And so I'm sure you all have a lot of questions. Keep your questions in mind. There will be time at the end to write those questions down, and we'll go ahead and get everything started for you. Okay, so we have a couple of interesting talking points for today. As you all know, having thyroid disease is very, very common. That we see this all the time in our primary care clinics. And we get a lot of questions about medication management, discussions about disease process, as well as, what can patients do at home in terms of their own lifestyle and nutrition to help manage their disease. So we have a very exciting lineup for you. We have our lecturers, Dr. Subi Bana, as well as our nutritionist, Marissa Mindler, and they're going to give us their input and insights on these topics. Okay, so I usually like to start these with a little bit of an activity or an exercise. So I want everyone to put their finger on their chin. Okay, so everyone's fingers on their chin. We're gonna look up. I'm gonna scoot down for this. And you're gonna go in from the middle all the way down until you feel kind of a hard pointy structure. And so that is often commonly known as the Adam's apple. Okay, so once you found that structure, you're going to go down just a couple centimeters and you're going to put both of your fingers to the left and the right side of your windpipe. So you see where I'm putting my fingers here. Okay. This is where your thyroid lives. Your thyroid is a little butterfly-shaped gland located in this area of the neck. If you have difficulty feeling it, you might try to swallow and see if you can feel that gland kind of move up and down underneath your fingers. And so this little gland, even though it's small, it's very mighty, and it makes hormones that control a lot of things within the body. When we talk about thyroid hormone, we mean what we commonly call in medicine as free T4. So I just want to set a foundation for our lecturers just so everyone has a really good base for understanding the talk that we're going to give today. So your thyroid makes thyroid hormone known as free T4. And if you have thyroid disease, you're probably familiar with the two most common hormones that are checked in your primary doctor or your endocrinologist office, and that is your free T4 and your TSH. So I'm just going to do a little brief education on what that is because that is really crucial to understanding today's topic. So TSH, what is that? That is TSH stands for thyroid stimulating hormone, and it is produced actually in your brain. And I like to think of it as kind of the manager that tells your thyroid gland what to do. So, for example, if somebody has an underactive thyroid or hypothyroid, your body signals to the brain that you're not getting enough hormone. And so your TSH, which is the manager of the brain, is going to jack it up, right, to tell your thyroid gland to make more thyroid hormone. Conversely, if you have an overactive or hyperthyroid, you're getting too much thyroid hormone in the body. So your brain, the manager, tells your thyroid, hey, slow that thing down. So your TSH is going to go way down. Okay? Does that make sense to everyone? Okay. If you have an underactive thyroid, what do you expect your TSH to do? We can use fingers, up or down. Okay. You expect it to be up. And if you have a hyperactive thyroid, meaning you have too much thyroid hormone in the body, what do you expect the TSH to do? Go down. Okay, great. Perfect. So now that we're all understood, I want to introduce our first lecturer, Dr. Subi Bana. He is an endocrinologist here at Torrance Memorial. He's one of my colleagues. I believe his office is right downstairs from my building. The cardiology building, yeah. He's our downstairs neighbor. He went to medical school at University of Aleppo School of Medicine and completed his training in diabetes, endocrinology, and metabolism at City of Hope Medical Center and Harbor UCLA Medical Center. Prior to specializing in endocrinology, Dr. Bana completed his residency training in internal medicine at St. Louis University Hospital in St. Louis, Missouri. He practiced as a hospital medicine physician for 8 years. He also served as the director of hospital medicine in an underserved community hospital. Dr. Bana seeks to treat all his patients with the highest level of compassion, respect, and clinical excellence. His areas of interest include diabetes, thyroid disorders, pituitary abnormalities, obesity, weight management and nutrition, as well as bone health. He is an active member of the American Diabetes Association and American Association of Clinical Endocrinologists. Everyone, let's welcome Dr. Bana.
Thank you, everyone. Okay, so thank you, Lana, for the introduction. This is my first time giving lecture for the Miracle of Life. Hopefully, it will be a continuous invitation. I hope everyone will enjoy the talk, and if you guys have any question, please feel free to write them down, and I will try to answer them as much as possible during the day today, or if you have anything urgent, we can talk about it later. So this is the thyroid, I'm going to talk or dedicate my talk today about hypothyroidism. And thyroid is, as Lana said, it sits right there, is a butterfly shape, a gland right there, right here. There is right lobe and left lobe, and there is a bridge in between. That is the isthmus. And if you ever heard parathyroid, and this is different than the thyroid, those are the little 4 glands, 2 on each side, responsible to control the calcium, the phosphorus, the vitamin D, the bone health. But our talk today is about the thyroid. So let's go back to the thyroid location. It's very important to regulate so many organs and so many systems in our body. So it has a very crucial role regulating metabolism, as well with the body temperature, weight, energy level, as well as cardiovascular system, from heart rate to blood pressure, GI system, as well. Mood can be affected if the thyroid is not functioning well. So thyroid disorder can be divided into function thyroid, which is the hormone portion, and structural thyroid, which is the thyroid nodule or thyroid cancer. I believe many of you did the scan, the ultrasound, the health screen, and I already got a few questions about the thyroid nodules. So those are not part of the talk today, but those are related to the thyroid structural problem. We will be talking about the thyroid functional problem, which is the hormone imbalance. So if the thyroid produces too much hormone, that's what we call overactive thyroid, and that is the hyperthyroidism, which is the medical term. If it produces less thyroid hormone, this is too little thyroid, and this is underactive thyroid, and this is the hypothyroidism. So a little bit medical terms here. You don't have to memorize anything, but it all starts. The thyroid regulation starts from the hypothalamus here, which is part of the brain. So it starts with the hypothalamus, and that releases the TRH. That hormone goes to the pituitary, which is the master gland, that releases the TSH, and which is the thyroid stimulating hormone. And that by itself goes to the thyroid through the bloodstream and stimulate the thyroid, or try to regulate the thyroid to produce enough thyroid T4 and T3. Now, T4 and T3 normally in every one of us the thyroid produce both T4 and T3, but the proportion is different. So we're talking about 14 times T4 compared to 1 time of T3. And then the body will convert those. So T4 is a prohormone or pre-hormone, and that need to be converted to T3, which is the active form. And that happens on any cellular level, any tissue, including liver, kidney, heart. Literally any tissue in the body has those enzymes that called deiodinase that will take 1 iodine from the T4 and make it T3, and that's what makes it active. The T4 and T3 has this ability that if the thyroid is producing too much, normally those levels in the blood go and inhibit through something called negative feedback mechanism, inhibit the hypothalamus and inhibit the pituitary. So there will be no more or no much of TRH and TSH. So that will be regulating the thyroid or help to regulate the thyroid. Hypothyroidism is the inability, or remember, hypothyroidism is underactive thyroid. And this is the inability of the thyroid to produce enough hormone in an efficient manner to meet the body's demand. And that results in several signs and symptoms that we will talk about in a second. Hypothyroidism is literally the second most common endocrine problem. So if we have to count the numbers of cases we see in endocrine clinic, number 1 is diabetes. Right after that is hypothyroidism. It's very common. The prevalence is about 3.8 to 4.6% of the population. It's obviously more common, you probably know that, more common in women than men. So we're talking about 6 to 1 or sometimes 10 to 1. So every 10 people will have, with hypothyroidism, one of them likely to be a man and the rest are women. Levothyroxine is the recommended medication to start when it comes to hypothyroidism, and this is per the ATA guidelines. And it is the third most common medication prescribed in the US after statin and aspirin and antidepressant. Causes of hypothyroidism, this is a busy slide, so I don't want you to worry about to memorize everything here, but I want to make it as informative and educational as possible. The most common hypothyroidism cause is autoimmune, which is the number one, Hashimoto disease or Hashimoto thyroiditis. Now, there are other causes of hypothyroidism, such as drugs, imidazole. Some people take imidazole. It's an old generation medication. Used to be, patient use it or doctor use it to control heart rate and cardiac arrhythmia in some patients. Lithium also can affect and destroy the thyroid gland. Antithyroid medication, those are the set of medication that being used in hyperthyroid or overactive thyroid to control the thyroid. And sometimes treatment itself can cause hypothyroidism. So surgery, for example, over there, where is it? Over here, thyroidectomy is a thyroid surgery or thyroid removal, sometimes partial, sometimes complete, that also can affect and cause hypothyroidism. A radioactive iodine ablation that sometimes is a treatment after thyroid cancer cases or can cause hypothyroidism. Radiation therapy for any other cause to the head and neck area sometimes affect the thyroid ability to produce enough hormone. And there are some infiltrative disease. Those are not as common, but we see them in a clinic, probably not in general population much, but amyloidosis and sarcoidosis, those are infiltrative disease, meaning that it affects the thyroid ability to produce the hormone, and over time, it will cause hypothyroidism. Back here, sorry. Iodine deficiency is not as common as before. It used to be very common in developed countries and third world countries, but less and less cases worldwide. Hashimoto disease, if you remember over there, the most common one is Hashimoto disease or Hashimoto thyroiditis. I wanted to give you a brief summary about Hashimoto. He was a Japanese surgeon and medical researcher that put this condition or described this condition back in 1912, and it wasn't recognized in the Western world. He put a paper in the German journal. No one paid attention enough until probably in the 1930s, where it got recognized, and then they named the condition after him. It is also can be named as Hashimoto thyroiditis, chronic lymphocytic thyroiditis, autoimmune thyroiditis as well. Those are all synonymous to the same disease. They are very common. Hashimoto disease, meaning that this is an autoimmune disease that the body produce antibodies, that those antibodies goes and attack the thyroid to cause destruction over time. So the antibodies themselves are very common. About 12 to 15% of the population have those antibodies. So it's not uncommon. The problem happens over time where those antibodies are able to destroy the thyroid and cause decompensation of the thyroid production and lead to hypothyroidism, which is at that time called Hashimoto hypothyroidism. So I want you to differentiate between the two. Hashimoto disease, there is no need for treatment because the thyroid is still able to produce enough hormone. Hashimoto hypothyroidism is the antibodies plus the symptoms of hypothyroidism, and yes, need to be treated. And not everyone with Hashimoto disease will eventually develop underactive thyroid. In fact, the majority of patients will live and die without knowing that they have Hashimoto to start with, or without developing hypothyroidism. The rate of developing hypothyroidism or overt clinical hypothyroidism is about 2 to 4% per year. The risk obviously is more common in women compared to men, and they are more likely to happen in older adults. People with other autoimmune disease, they tend to have Hashimoto disease as well, because those autoimmune problem comes as a group. So type 1 diabetes, celiac disease, lupus can present, or the patient can have those, and then later on in their life, they develop Hashimoto disease as well. First degree relatives, Hashimoto disease tend to run in a family. So some families have those antibodies more frequent than other families. The signs and symptoms of hypothyroidism. I'm sure probably a lot of people here knows what thyroid symptoms look like, but they are also unspecific, meaning that every symptoms by itself is not specific to the thyroid problem, but the constellation of symptoms together, along with abnormal blood test and the clinical picture, can form the diagnosis. So signs and symptoms of thyroid problem, such as unintended weight gain, fatigue, muscle weakness, constipation, dry skin, hair loss, slowed heart rate, brain fog. A lot of patients describe that, difficulty concentration, memory issues, depressed mood, and digestive issue as well. And in premenopausal women, irregular menstrual cycle also can be attributed to uncontrolled or untreated hypothyroidism. So as I said, the diagnosis is based on a blood test and the clinical picture. So the patient will have more than one symptoms of hypothyroidism in conjunction with the elevated TSH and low free T4. Oops, what happened? I need help. Oh, thank you. The treatment of hypothyroidism is very easy. We start the recommendation, the American Thyroid Association, which is the ATA, recommend hypothyroidism to be treated with levothyroxine as a first line. And this is the T4 that the thyroid produced. This is the synthetic version of the T4 that the thyroid produced. And then the body will be able to control the conversion rate to T3. It is weight-based. As a rough estimate, we'll talk about how we start the levothyroxine in a next slide, but it's usually weight-based, and it is in most cases, almost all cases, is lifelong treatment. So levothyroxine, as I said, is a synthetic, meaning lab-made medication, and this is the generic name, levothyroxine. The brand name could be Tyrosint, could be Synthroid. There are a lot of brand name on the market. It's easily absorbed, and 60% to 80% in the small intestine. The half-life, meaning that the medication stays in your system for about 6 days. So the dose you take today will have effect all the way until 6 days after the dose. Stable hormone level when it comes to levothyroxine, that's why it's the #1 preferred medication. And it has a safety profile as well as more steady plasma level or blood level. There are other forms of treatment as well. We'll talk about them in a second. Now, starting levothyroxine, as you can see here, as a rule of thumb, for normal adult, we start with 1.6 microgram per kilogram per day. And that is not one size fit all. So if the patient is healthy, middle age, this formula will work. And this is a rough estimate based on the weight. However, if the patient is pregnant, we usually tend to increase the patient's prior thyroid dose by 25 to 30%. Or if it is first time hypothyroidism during pregnancy, we start between 2 to 2.4 microgram per kilogram per day. Now, older patient, we tend to use conservative dose, lower dose. We usually start 25 to 50 microgram per day out of caution, and then go up on the dose as needed. So we start low and go slow. And then for patients with cardiac disease, such as cardiac arrhythmia, AFib, we need to be very cautious not to trigger the rapid heart rate or cardiac arrhythmia, or not to trigger AFib and cause more palpitation to the patient. So we usually start very conservatively, 12.5 to 25 microgram per day, and increase as needed to achieve the target TSH and free T4 level. I'm not touching here anything. I don't know how to get this out. Okay. The medication, the levothyroxine medication, is very sensitive medication. So it needs to be taken on empty stomach, first thing in the morning, wait about 30 minutes, preferably more, 45 to 60 minutes. But if you can wait at least 30 minutes, it's reasonable. It's okay to, and then you can eat after that. Water is fine. Caffeine, coffee in the morning will affect the absorption, if you need to remember that. Can also, thyroid medication should not be mixed with calcium, iron, antacid, should not be mixed with iodine. Some multivitamin or some supplement, over-the-counter supplement, may contain kelp, which is iodine, and that also can affect the absorption. I want you to look at the list of medication here that can affect thyroid absorption. If any of those medication is on the patient list, those need to be taken 4 hours apart so it doesn't affect the absorption. And seizure is not that common, but seizure medication, clear levothyroxine out of your system faster. So in order to compensate for that, usually we give the patient a little bit more of the medication to last longer and keep the hormonal balance, because those medication will make the half-life of the medication shorter, and that will be out of the system. So it's not a tricky medication, but if you know the basic, how to take it, what to avoid, and when to take it, and when to take the other medication that may affect the absorption, you will get the best results. Usually thyroid, once we start the thyroid medication, it will take about 4 to 6 months to regulate the thyroid. And once we start the medication, I usually recheck the thyroid hormone level, TSH and free T4, anywhere between 4 to 8 weeks after the initiation of the medication, or anytime we change the dose, we need to make sure that the dose is not going to be overcorrecting or undercorrecting. The TSH goal for adult is 0.5, rough estimation, 0.5 to 4.5, and it depends on the lab reference range. Some labs have a higher reference range, up to 4.9, some will have lower. Older patient, it's okay to have TSH elevated. Up to 6 is totally acceptable. There is a European study also suggesting that for older patient, we take the patient age and divide it by 10, and that will be the upper limit of the TSH. So if the patient in their 80s, the TSH can be normal or should be considered normal up to 8. Semi-annual or annual monitoring for hypothyroidism patients is reasonable as long as the medication dose is the same. Now, other thyroid medication or other treatment option is T3. Remember that active thyroid hormone, the T3, that the body convert T4 to T3. Now we can take T3 readily available, but at a low dose, and we cannot start only T3. It always needs to be combined with T4. So you can take T4 alone and T3 alone, or you can take the combination of the medication. And there are different routes for thyroid medications, such as IV. We use it at the hospital. IM, which is intramuscular injection. If the patient is not able to take the oral medication, there is sublingual as well. Last resort for some patient, I've seen those cases in psych unit that the patient refused to take the medication. You can give them as a weekly dose. So if the patient is on 75 microgram daily for 7 days a week, we take all those 7 pills and give it 1 day a week as a treatment option, but this is not a common thing. Synthetic leothyronine, which is the T3, again, it's faster absorption. It is the active form of the hormone. It's shorter half-life, and it's usually used, we use it only for myxedema coma, which is a severe uncontrolled hypothyroidism. Also, some patient with hypothyroidism, even though they are on T4, they still have this nagging fatigue or low energy or feeling muscle weakness. And it is okay to try T3 in those patients. Actually, the satisfaction of patient will be higher, and the quality of life, a lot of studies indicating that the quality of life will improve if you combine the T4 to T3 just in this subset of patients. And there is off-label use for T3 in severe depression that it enhances the antidepressant effect. The combination therapy, the T4 and T3, remember, T4 and T3 produced by the thyroid, normally the rate is 14:1. Those combination of medication is 4:1. So the T3 proportion is much higher, and that sometimes is aggressive on the body because it's not mimicking the natural way or the natural hormone ratio. And that's why T3 always need to be much less and very calculated dose, because otherwise the patient will have the side effect of the medication without the benefit. There are synthetic T4 and T3, and there are desiccated thyroid extract, which is also a combination, usually animal derived, and those are usually from pigs. And we probably all heard of the Armour thyroid and MP thyroid. And those are common medication. A lot of patients used to use them, and they refuse to go back to levothyroxine. However, those are not totally approved by FDA to use. We can use them off-label. They are acceptable. They are not regulated, but on a clinical level, they are giving good response to patients, especially the patient that did not respond to levothyroxine alone. They are not first-line therapy. Now, levothyroxine, the synthetic one, is not ideal. It does help a lot with the thyroid patient, but they are not. They didn't meet all patients' needs. So there are still work to do, including improve formulation, fewer additives. Some patients, they don't like the generic levothyroxine, for example, and they prefer brand name because there are less additives to those medications. Some people are sensitive in terms of GI sensitivity, that they do prefer some brand name. So levothyroxine or synthetic is the right treatment, but it may be not appropriate or not helpful to all patients with hypothyroidism. We also still need some easier absorption medication to help achieve a better and more stable level. So those are all potential medication formulation in the future. Now, I just want to point out to the liquid and soft gel levothyroxine. The brand name is Thyroid, or any other liquid with levothyroxine. Those are indicated for certain individual with GI malabsorption problems, such as celiac disease or lactose intolerance. Those are probably the cases that will benefit from those liquid levothyroxine. And also for patient with history of gastric bypass surgery, those patients have very less gastric acidity or acid production, and acid is needed to absorb levothyroxine. So if you have less acidity in your stomach, you need a liquid form to be absorbed better. And this is okay to switch from the tablet form of generic to more of a liquid form of levothyroxine. In conclusion, hypothyroidism is very common. If you remember, it was the second most common endocrine cases in our clinic, and it's easily treated if you confirm the diagnosis and confirm it with not only clinical, but also with biochemical blood test. And once you confirm the diagnosis, it's easy to treat. You put the patient on levothyroxine. Adherence to the medication is very important, and taking the medication correctly and avoiding other medication that may sometimes affect the absorption is essential. Monitoring periodically is also important to achieve the outcome and improve the hormonal balance for the thyroid. Thank you for listening.
Thank you, Dr. Pana, for that very informative lecture. I would say, yeah, I think the main overarching theme here is that the treatment of thyroid disease is very nuanced. I think in primary care, one of the biggest, issues that I see is knowing how to take the medication. So making sure you really are taking it first thing in the morning on an empty stomach. And supplements, are you taking supplements close to the time that you're taking your thyroid medication? Because that is also something, as Dr. Bana had said, that can impact the absorption of the medication. Okay, so I think oh, yes. So for questions, if you don't mind holding off to the very end, we're going to give you some a paper to go kind of write everything down. Okay, so I think now might be it might be fun to do a case study. It'll be a very simple case. So let's say, for example, you have a 65-year-old woman with abnormal thyroid function testing. And let's say her free T4 is normal, but her TSH, remember it gets made in the brain, the manager is elevated. Why might that be? You don't have to shout it out, just think about the answer. Why would somebody have an elevated TSH and a normal free T4? Right, but we had said earlier, right, that the free T4, if we would expect that to be low in hypothyroid. So why would this person's free T4 be normal with an elevated TSH? So this is a situation that it's called subclinical hypothyroid. And essentially what it means is that your thyroid makes the right amount of hormone, but you're just working harder than normal to produce the correct amount of hormone. So let me take it one step further. Do we treat this problem? Maybe we can shake our heads, yes or no? Let me see what the majority thinks. Okay, I see a couple no's and I see a couple yeses. Okay. So the answer is it depends, right? It's really nuanced. So we look at a bunch of different things. We look at your age, we would look at your actual numbers. We look at whether or not you have antibodies, right? We look at whether or not you have heart risk factors, and whether or not you have symptoms, right? We listed a whole list of symptoms of hypothyroid. So all of these things would go into the decision of whether or not we treat something like a subclinical hypothyroid. Okay, so I think that's just a fun little brain teaser, but we can move on. I think there's the next topic is really more nutrition based, because aside from medications, a lot of people want to know, like, hey, what can I do just in my everyday life? that I can, what changes can I make in order to help with my disease management? And a lot of people want to be proactive with their thyroid disease, and I think that's great. So I wanted to welcome our next speaker, Marissa Mindler. She is a registered dietitian nutritionist, driven by her motivation to educate and assist people in achieving their health and wellness goals. Graduating from USC with both a BS in kinesiology and an MS in nutrition, she has always been interested in the impact of nutrition on oncology, fitness and performance, and women's health. During college, she was also a successful track and field athlete competing in throwing events and has been a dedicated personal trainer for 12 years. After completing her internship at USC's Norris Comprehensive Cancer Care Center, she has been inspired to help patients stay nourished as they navigate a challenging time throughout treatment and into survivorship. She currently teaches the Cancer and Nutrition series, Nutrition During Cancer Treatment, Live Well After Cancer, and Cooking at Home classes, along with offering individual nutrition counseling sessions in radiation oncology and at Torrance Memorial's outpatient medical nutrition therapy office. Please welcome Marissa.
Thanks, Dr. Shi, for the introduction. Appreciate it. Hello, everyone. Good evening. So everybody is now officially experts in the thyroid, right? I would like to say I am not an expert in the thyroid, but we will hopefully give you some wonderful information today about just nutrition and how it does play a role in thyroid health. And then we'll discuss some things as it relates to diet, what you can do lifestyle-wise. So I'll just kind of briefly do a review of some of what Dr. Bana said. We'll talk a little bit about the thyroid, where it is, but you guys are all experts now. We'll talk about some basic thyroid diseases, metabolism and the hormones. And then most importantly, we'll go into some nutritional micronutrients as it relates to the thyroid. Okay, and then we'll talk about the diet. So everybody find your thyroid. Point to it. Dr. Shi, how'd you do it? Yeah, exactly. So yeah, it's just that butterfly-shaped gland. It sits right behind or around your trachea. It also has those parathyroid glands, like Dr. Bana said, and those are really important as well for nutrition. They play a role with phosphorus regulation, calcium, and bone health. Okay. But the thyroid is really like what the doctor said there. It's the manager, it's the master, right? It controls a lot of physiological processes. Primarily, those are obviously related to metabolism and energy. So it can play a role in fat breakdown, muscle contraction, bone growth development, elevate our heart rate, as they said, and it can impact specific nutrient digestion and absorption. Common diseases, these are a little bit more related to autoimmune conditions. Hashimoto's thyroiditis, again, an autoimmune condition that causes hypothyroidism. There's also Graves' disease. Not sure if anybody has that, but it's where it's the opposite, right? So this is an overactive thyroid, again, an autoimmune condition that can happen. And goiter, this is far less common, particularly in the United States. I'll get into why that is the case. But goiter can result from an iodine deficiency. Okay? And a goiter is just an enlarged thyroid. So if we think about how the thyroid signals, okay, the hypothalamus in your brain sends a message to your pituitary gland. Okay, and that pituitary gland releases thyroid stimulating hormone. Okay, that tells our thyroid to release and produce the T4 and T3. Okay. So TSH, thyroid stimulating hormone, right? Again, like I said, it tells the thyroid gland, to produce T3 and T4. Okay, T4 or thyroxine is really the inactive or subactive form, right? T3 is the one that has the greater effect on metabolism. So like Dr. Bana said, T4 is actually produced more, but T3 produced less, but it has a stronger effect. So he mentioned some of the dosing with those medications, a lot different. Right? Calcitonin is another hormone that the thyroid produces, and this actually regulates the amount of calcium that is in our blood. So this just serves as a purpose for understanding that we are not a closed system, right? Humans are hormones, our glands, our organs. We're not a closed system. We have signaling, right? Our brain signals all of these different hormones to do different things. But we also respond to our environment. We have things like stress, right? Everybody has stress. We have external things in our environment that we don't even know about that are affecting things, right? So, oopsies, oh dear. So we are not a closed system, right? And when we think about autoimmune conditions, again, Hashimoto's, Graves' disease, these things can all be affected from your environment, right? It can be genetic related. But this image also serves to show that nutrition can play a vital role in the regulation of some of your hormones, and also just general health and wellness, right? So when we think of autoimmune conditions, we think that this can be a response to some form of what we call oxidative stress. Has anybody heard of that term before? Maybe, not really. So just it's a term that means damage to your cells, okay? Damage to our body cells, oxidative stress. It can happen from the sun. We can get skin cancer, okay? Especially if you go unprotected in the sun. But oxidative stress is complicated because it's very difficult to measure, right? It's very hard to understand, well, where is this coming from, right? But different things can cause damage to our cells, and that can cause damage to the DNA, and that can trigger some level of autoimmune conditions. Okay? So you see all those micronutrients, the iodine, the selenium, zinc, vitamin D, and your omega-3 fatty acids. Today, we're going to mostly focus on iodine and selenium, but all of those other ones I will casually mention towards the end. All right, so iodine number 53 on the periodic table. I know everybody remembers that, right? No. So this is a thyroid cell. Okay, we're going to talk about how iodine is involved in metabolism. Now, this image should terrify you. I know the doctors are probably like, oh my gosh, bringing me back to Bio 101, right? So iodine is involved in the synthesis of T4 and T3. Okay, oh my gosh, what happened? Tech. I know. Sorry, everyone. Well, there we go. Thank you. Appreciate it. So it's involved in the synthesis of T3 and T4. Okay, so if you look at the bloodstream there, right? So let's just say we eat something that contains iodine. We'll talk about that after this. And iodine gets shuttled into the cell, okay? And it gets into this center part of the cell. And a really special protein called a thyroglobulin interacts with iodine. And through a series of very complicated steps, we make T3 and T4. They then get pushed out into a little protein bubble, that's what we'll call it, and shuttled back into the bloodstream to travel to different tissues. Interestingly enough, 7 iodide ions are used to make one T3 and one T4. So you think about the number of cells that are in the thyroid, millions, right? So think about how much iodine we're using on a daily basis, right? Really, really interesting. So that is the role of iodine in this metabolism. So where do we get it from? Well, iodine actually exists in various soil content all across the globe. It's also found in different groundwater, and it's very much dependent upon your location. So the United States, everywhere on the globe, okay? Common sources, so you see here, we've got seaweed, okay? Who likes seaweed salad? Hopefully, maybe you'll like it after this. Seaweed. So seaweed is one of the top contributors to iodine, but we also have things like cod or haddock, certain shellfish. We've got your cranberries, different dairy products, so cheese, milk, yogurt, eggs. We've also got potatoes, some other leafy greens. prunes. And then at the very base here, we've got iodized salt. Okay. So the RDA, which just stands for the recommended dietary allowance. Okay. This is really the minimum amount that we would want to consume on a daily basis, is 150 micrograms per day for adults. It goes up if you're pregnant or if you're lactating. And the tolerable upper limit, that just means really the maximum amount that anyone could consume that would be unlikely to cause any sort of adverse health effects, is 1,100 micrograms per day. So let me see if I remember my numbers right. A quarter of a teaspoon of iodized salt provides about 45 micrograms of iodine. Okay. So if you look at a lot of these sources, I mean, you see seaweed, right? And we see like other fish that live in the sea. You would think that sea salt would have some iodine. It does, but not nearly as much as iodized salt. Okay. So we wonder, well, why the heck would we have iodized salt? Where did that come from? Well, it was actually started in the 1920s. Okay. And it was a public health initiative to essentially prevent goiter. So back in the early 1900s, this top part of the United States was struggling with goiter. Okay. And it was simply because that area of the United States, the soil just was not rich enough, the diet that didn't contain enough iodine. So they said, well, we got to do something about that. So they iodized the salt. And it actually became mandated in a variety of different countries around the world. 21 countries still leave it voluntary, but as of 2020, 124 countries actually mandate salt or iodine to be added to salt. So if you look at this map just shows, as of 2020, really where insufficient iodine intake still exists. But you can see most of the world is adequate. So adequate is going to be this gray color here. You see there's quite a few countries that are all gray, again, likely due to the iodized salt program. But you can see a few places actually have some excessive iodine intake. Colombia and some parts of Africa and Pakistan. So kind of interesting. I would imagine it has to do with the soils, probably certain parts of the diet. But I found that very, very interesting. And you can also see that there's a large section, Russia, that does not really have adequate iodine intake. Very interesting. So this is a big word, a goitrogen. Okay, so a goitrogen is really just a food that reduces the absorption of iodine. Okay. Now, when we think about this, generally for the majority of the population, we don't really have to worry too much about this. But if you have an autoimmune thyroid condition, you might want to pay a little bit attention to how much of these foods you're having and the timing, perhaps, that you're having these foods. So cruciferous vegetables, soy foods, cassava, strawberry, peaches, flax seeds, red wine, certain teas, they can all affect the absorption of iodine. Now, I would also like to state that there are many different foods that affect the absorption of many different things in other foods, okay? So if we really thought about all of that, we probably wouldn't eat anything, okay? We would be too paranoid to eat anything, right? So this is really very minor. It really doesn't affect the average person. So you don't really have to stress about this, but just keep it in mind, just kind of something to think about. Also, a really interesting fact is that if you steam or if you boil foods like broccoli or kale or cauliflower, it actually can reduce the effect, the goitrogenic effect, so its ability to reduce the absorption of iodine by 30 to 65%. So I thought that was kind of cool too. Yeah. Vice versa, if you ferment any of these foods, it can increase the effect. So food science, right? Very, very interesting. Chemistry. Okay, so a couple just mentions about food interactions in thyroid medication. So with levothyroxine, as the doctor said, take it on an empty stomach. Okay, very, very, very important to take it on an empty stomach. Why? Because of some of those effects, right? Because of the fact that it can bind very sensitively to different things in the GI tract and reduce the absorption. So at least an hour before you eat, try not to take it with any sort of caffeine. And then these types of foods, so soy foods, walnuts, flax seeds, grapefruit, they can all have sort of a strong effect as far as reducing the absorption of the medication. So it's actually recommended not to eat those foods first thing, right, after you have taken your medication. If you are taking supplements, so like iron supplements, if you have anemia, calcium supplements, if you have osteoporosis, same with magnesium. I know magnesium has started to make a huge comeback. But if you take any of these supplements and you're taking this medication, you should wait at least 4 hours before you do that. Okay. Again, these have a very strong interaction with the medication and can bind very closely with it and reduce its absorption. These other ones, PTU and methimazole, those are for people who maybe have Graves' disease. They don't really have any interaction at all. Okay, now y'all are experts in iodine. You're gonna go have a seaweed salad tonight. Let's talk a little bit about selenium. Has everybody heard of selenium? Has anybody? No? Yes? Maybe? Sort of? Yeah. So selenium is pretty cool. Okay. It has a lot of different functions in the body. It certainly relates to the thyroid, but it also has really strong effects when it relates to fertility, brain function, bone tissue. So selenium has a greatest effect in antioxidant properties. So remember we heard the term oxidative stress, and now we have the term antioxidant. Okay, so things like vitamin C and vitamin E, those are considered to be antioxidants as well. Okay, so what they do is they prevent damage to our cells, damage to the DNA. Okay, so selenium has very strong antioxidant properties. Now that first picture was probably very scary. This one's even more scary. So this just goes to show the complexity of biology and the complexity of even just thyroid metabolism. But selenium works in a couple different places. So you can see right here, and it also works over here. So this GPX, okay, stands for glutathione peroxidase. Okay, all that is it's an enzyme. Okay, it's a really fancy enzyme that actually helps with antioxidant capacity in our body. Okay, many cells contain glutathione peroxidase, and selenium is involved in that reaction. Okay. Selenium over here as well is also involved in the conversion of T4 into T3. So remember, it was T3 is the more active form. So selenium is responsible for helping it become more active. We got tech issues again. I'm not in. Let's see. All right. So where do we get selenium from? You can see there's a lot of overlap from iodine. Okay. So Brazil nuts, walnuts, pumpkin seeds, other seafood, so sardines, haddock, chicken and beef also contain selenium, mushrooms, potatoes, peas, eggs. Again, a lot of overlap, right? The RDA is 55 micrograms per day. Pregnancy, again, goes up 60 to 70. And then the upper limit is 400 micrograms. All right, let's talk a little bit about diet. So before we do that, who wants to tell me all about thyroid metabolism again? Okay, so this looks beautiful, right? What kind of sticks out to you guys? What do you notice? Color. Yeah. Why do we care about color? We care about it because of antioxidants. Okay. So everyone has heard of the Mediterranean diet. Yeah. Oh, yeah. Yeah. I'm kind of tired of it too. No, I'm just kidding. I'm just kidding. So I put the Mediterranean diet in quotations. Okay. Because this does not mean that you have to eat like the region of the Mediterranean. Okay. The Mediterranean diet is really a skeleton protocol, right? It is a structure that can be adjusted to any culture. It just emphasizes certain types of foods and proportions of those foods across the day, across the week, or across the month. Okay. So the Mediterranean diet is more plant forward, and it has been shown to have an improvement in autoimmune thyroid diseases. Okay. Why does it do that? It has been shown to reduce inflammation and that oxidative stress that we talked about. Okay. We are generally consuming a lower amount of saturated fat that helps reduce inflammation of the cardiovascular system. Okay. Increasing fiber intake to support our microbiota. So a couple slides back, this scary pic, we have this up here, right? And you can see that our gut microbiome is very closely correlated to the modulation of the immune system. Okay. And the immune system is how we think about autoimmune conditions. Right? So if you intake enough fiber in your diet, okay, your gut bacteria will ferment that fiber in the colon and they will produce something called short chain fatty acids. These are helpful fatty acids that actually help work different systems and again have been shown to promote overall health and wellness. Okay. We get a higher intake of antioxidant compounds and phytonutrients when we follow a Mediterranean diet. So lots of fruits, lots of vegetables, lots of color. Okay. If you are consuming fish and seafood, if you're consuming walnuts, pumpkin seeds, chia seeds, if you're eating these types of seeds, you're getting a lot of increased omega-3 fatty acids. Omega-3s have also been shown to help reduce inflammation. And you're going to get iodine and selenium. So we're on a pyramid kick in this country right now, but we're going to revert it. And we're going to talk about the Mediterranean diet in this aspect. Okay. So what do you guys see at the bottom there? Yeah. Grains, beans, nuts, fruits, carbs. Yes. Fruits, vegetables, right? So the idea is that those should make the base of your diet. Okay. You should be eating fruits. You should be eating vegetables. Does anybody know what the recommendation is for fruit intake per day? 1 to 2 cups. Okay. 1 to 2 cups of fruit per day. Okay. How about vegetables? 2 to 4 cups per day. Okay. 10% of Americans are meeting this goal. I would like to say that 10%. Okay. But everybody in this room, as soon as we leave, is going to meet that. Okay. So fruits and vegetables. Okay. Fruits and vegetables. That's where you get the fiber and the color. Okay. Whole grains, focusing on whole grains, things like brown rice, things like quinoa, farro, okay, jasmine rice. These are all should be the base of your diet. Okay. Moving up the ladder, we have some intake of olive oil. It could also be avocado oil and other different seed oils. Okay. Then we move up the ladder a little bit. This is where we get to a more moderate intake. So a few times per week, you should be having fish or seafood. If you cannot eat fish or seafood, or if you do not like fish or seafood, you should be emphasizing nuts and seeds. Okay. Eggs, poultry, cultured dairy. So this is going to be things like cottage cheese, Greek yogurt, kefir. All of these types of cultured dairy are helpful for our gut bacteria. Okay. Finally, we get to the very top here, which you can see we want to eat a few times per month or less. Okay. Sweets and added sugars and things like red meat. So this includes pork, beef, lamb. Okay. But we missed something that was really important. Physical activity and hydration. Okay. Daily physical activity and movement is essential. Okay. All of this plays a role deeply into our immune system and it plays a role into our health, our wellness. We also saw vitamin D was important, right? Go outside, sit in the sun, please. Your body will thank you. Okay. So get outside, go in the sun and drink some water. So how can we do this? Okay. Practical tips for incorporating generating Mediterranean diet. Maybe add a small salad with your breakfast in the morning. Okay. Have a serving of mixed nuts with some fruit. Maybe make a grain salad or add some quinoa, farro, or other whole grains onto a salad. Mix some leafy greens into your soup or stew. And for a snack, consider having vegetables with some bean dip. Okay. Very simple things that you can do to make a huge difference. Right. Thank you guys for your time. This is our website, so if you have any questions, we will take them next. But please go to torrancememorial.org/nutrition if you have any questions, or if you're interested in making an appointment with any of us. Thank you, guys.
All right, let's get started. This is my favorite part about these talks is going through the questions. Okay, so the first question is, please explain about the bulging eyes of Graves' disease and surgical options.
Okay. So Graves' disease ophthalmology problem or orbitopathy is the bulging of the eyes. Not everyone with Graves' disease will have that. It's those antibodies that, first of all, Graves' disease is autoimmune thyroid disease. So those antibodies go to the thyroid and stimulate the thyroid to overproduce and cause excess in production and release of the thyroid hormone. That's on the thyroid part. The same antibodies goes to the tissue around the eyes and stimulate as a growth factor. So those cushion around the eyes get hypertrophy or increase in size, and that will push the eyes out. Surgery is an option for severe cases. There are medical treatment that comes with good result, good outcome, but also not everyone is candidate. So what I would recommend my patient with Graves' disease and orbitopathy is to go to certain clinics, not general ophthalmology. The ophthalmology clinic that is specialized in thyroid eye disease, and that will be very informative and very useful for the patient. TED Clinic, TED, TS Tom, or thyroid eye disease, is the clinic that you need to look for when you call ophthalmology clinic if you have Graves' disease with eye problem.
And kind of building on that question, is Graves' disease curable?
It can go in remission. It's case by case. It depends. It depends on the age, the gender of the patient, if what kind of treatment they are receiving, the dose that they are receiving. And most cases, or probably 50-60% of cases, can go into remission, but the remission usually take years, 2 to 3 years minimum, with appropriate supervision and medical treatment. Yes, it's not lifelong. Some Graves' disease can go in remission, but the patients still carry the risk of flare-up or recurrent Graves' disease again in the future. So it may go into remission, but then it will act up again and go in a flare-up mode, and that will need another treatment course, and it may or may not go back in remission. So some patient will go in and out in Graves' disease over decades. So case by case, but it is not lifelong, not always.
And I know earlier we had talked about making sure we take levothyroxine for hypothyroid in the morning on an empty stomach. I have a question here that's asking if methimazole, which is a treatment for Graves' disease, needs to be taken the same way, or can it be taken anytime during the day?
It doesn't have to follow the same rule for the thyroid, for the levothyroxine. It can be taken any time of the day, but stick to the same schedule. So if you're taking it at noon, always take it at noon. Food doesn't matter. So you can take it on empty stomach or not empty stomach.
Okay. Let's see. At what age do folks start noticing symptoms of hypothyroidism? Only seniors or younger?
Say that again.
At what age do folks start noticing symptoms of hypothyroidism? Only seniors or younger?
It can happen in all ages. I have patients, they were diagnosed with hypothyroidism in their 5 year of age, and I have patients in their 80s, they start having hypothyroidism and needed treatment. So it can happen at any point of life.
Okay, I have a couple nutrition questions here. Should we be taking iodine and selenium supplements to get closer to reaching daily needs?
I would only generally recommend supplementation, perhaps if pregnancy, lactation. If you have allergies to certain foods, then it could potentially be necessary to look into a supplement. Most multivitamins actually, I don't think they contain iodine. Prenatal ones will. But if you are unable to consume some of those foods that were listed that have those items, then yes, perhaps supplementation might be necessary.
Do you have an opinion regarding different types of cooking oil, such as canola, corn, vegetable, or peanut oil for cooking?
Hot topic, hot topic. No, not really. I would say that there are certain oils that can have what's called a higher smoke point. So avocado oil has a really high smoke point, meaning it can be better at higher temperatures. I think duck fat also has a really high smoke point. Corn oil, I believe, is a little bit lower in smoke point, but most of these things, it's more related to the way that it's processed. I'm not really a food expert when it comes to the processing of oils. So generally, olive oil is safe. Avocado is great for high heat temperatures. Canola oil is also healthy. I would say that may be better at moderate temperatures as well.
Okay, so the next question is, when does thyroid disease become cancer, or does it become cancer?
So I would love to differentiate between the two. Thyroid disease does not convert to cancer. Thyroid cancer is a structural problem. Remember, there is a structural problem and function problem. The hypothyroidism is a functional hormonal problem, and the thyroid cancer is a structure problem. It starts as a nodule or thyroid cancer. Risk, it depends on family history, age, radiation exposure to head and neck area, if there is any other cancer that was treated in the past and the patient underwent radiation therapy, and then they did CT or any kind of imaging or ultrasound and they found thyroid nodule, it's case by case to detect and do the biopsy and proceed from there. But back to Hashimoto, if you remember, Hashimoto disease is one of those, the other name for it is a chronic lymphocytic thyroiditis. There is some link between those Hashimoto disease, a very, very, very rare cases with lymphoma in the thyroid. And lymphoma of the thyroid is classified as one type of cancer, thyroid cancer. But again, those are very, very rare. So the simple answer is no. But in a very, very rare level, Hashimoto disease can convert to lymphoma of the thyroid. Again, very rare. Can't stress that enough.
Yeah, I get that question a lot too in primary care, so I often try to make that distinction as well. Okay, so the next question is, this person was taking generic medications for their Hashimoto's and found that it was less effective than the brand name Synthroid. I think you kind of touched on this. They're asking why is it, and it felt like a big difference.
Individual response exists. I don't want to downplay patient's preference or patient symptoms. Patients are the number one that can tell if the treatment is working or not. Not only the clinical picture, not only the biomedical or the biochemical level, which is the blood level. It's the patient himself or herself can tell if the medication is working. So some individual may not absorb the medication, or the medication has some additives, or the formulation of the medication doesn't sit well for this patient specifically. It shouldn't be a rule, but I don't mind switching from generic to brand name if the patient truly benefit and believe that it is helping the symptoms. So to answer, it's more likely related to the additives that is on top of the active ingredient or the medication, that the way to form the tablet or additives to keep the tablet in a good form to be delivered and taken by the patient.
Can menopause play a role in thyroid conditions?
can be triggered, yes, can amplify the symptoms sometimes. And this is where it become a little bit tricky to understand if those symptoms are related to the perimenopause or menopause, or are they thyroid related. And this will take close follow-up, multiple blood tests, and investigating other hormonal imbalance that can be triggered by the menopause itself, with or without thyroid disease on board.
This person asks, can I have a milkshake and a coffee latte 2 hours after having 2 hours after taking my levothyroxine in the morning on an empty stomach?
Yes. Please share.
Some people like to take thyroid support supplements. Are they able to take that in addition to their levothyroxine? And is there any additional benefit to doing
That's
so?
a very good question. The answer is I can't tell you. I don't know the answer because some of those thyroid strength formula, they actually have thyroid hormone in them without being disclosed to the patient. Or I remember this case, patient was using thyroid boost he got it from outside the country, and his thyroid, he was seeing me for different reason, but his thyroid level was showing as if overactive thyroid. And we investigated everything from thyroid ultrasound to blood test multiple times. And then when we reviewed the medication, nothing was remarkable. But then when we asked about the supplement, he brought the supplement the follow-up visit, and it was showing that it has T4 in it. And so the patient was trying to take care of his thyroid in a healthy way or keep it healthy, but he was actually causing harm to the thyroid because he was taking thyroid supplement without knowing thyroid hormone in those supplements, and that caused overactive thyroid. And in fact, his thyroid shrink over time, the atrophy, the gland got smaller in size because it's not working anymore, because the thyroid hormone is coming from the boost from the supplement. So the thyroid was not making any more hormone, and over time, over several months, got smaller in size. So be careful about those supplements. I would use something trusted, reputable company, and read the label and make sure there is no ingredient that is active hormonal formula or T4 or T3. Yes.
I just kind of want to add a little bit on the supplement line. So supplements are not regulated at all in this country. Okay. I can scoop up dirt in my backyard, put it in a capsule, and sell it to you. Okay. It's kind of scary, actually. Okay. The supplement industry is $1 trillion industry. Okay. The incentive is simply money. Okay. Money, marketing. That's what the supplement industry is. Now, there are some moderate checkpoints. Some supplements can be third-party tested. There are a subset of different companies that do this. NSF, the National Sport Federation, is one of them. So it has a little NSF label on it. Only a handful of products are NSF certified. This is going to be actually what a lot of professional athletes will take as far as supplements and vitamins, because they are rigorously tested for adulterated substances, making sure that what you're actually getting on the label is, what you're actually taking in the capsule form. But I would say 95% of supplements are not tested. Okay. So you can pick something off the shelf and you actually genuinely have no idea what's in it. And there was a study done not too long ago that found that almost 80% of supplements contain things in them that were not on the label. Okay. Hormone health is highly, highly marketed. Okay. So genuinely, most of these supplement companies, it's just about money. Okay. So this goes for vitamins, minerals, herbs. And you also have to be really careful with these things because they may interact with medications that you're on. Okay. We're also seeing some people come into the hospital with kidney damage and liver damage because they're overdosing on these supplements. Okay. Liver enzymes are elevated, things like that. So I just caution everybody, like if you are taking supplements, just make sure that, it's a regulated or, checked supplement. Okay. Bring all of your things in with your doctor when you go see your doctor. Okay. They may not know, but you can also, if you make an appointment with us, you could also come and bring it and we can check it for you. Okay. But truly be careful with supplements.
Okay, I think we probably have time for one more question. Does exercise increase absorption of nutrients?
Yeah, definitely. Exercise helps you like use carbohydrates, helps you use fat, helps you use protein. Exercise is essential. 100%. Exercise is necessary. Okay, so yes, it does help you use nutrients.
All right, thank you so much. Give it up for Marissa and Dr. Bana. We'll hang out here for just a couple minutes. So if we didn't get to your question, feel free to come and chat. But we'll be here probably until 8 p.m. Thank you.